Thank you very much, SIMAR, and thank you for giving me this topic and to be able to participate in the course. The topic that SIMAR has given me is complex retinal detachment, diabetic, and vasculitic. Now, let's talk about diabetic. Important before you take up the patient for surgery is good metabolic control. Pre-op anti-VEGF agents may be given because they do reduce intraoperative bleeding, but be sure that the patient has all the clearances before you inject in anticipation of surgery. Pre-op PRP is important in diabetic patients, and while doing PRP, maintain a safe distance from the base of the fibrous membrane. Now, there are certain videos and tips that I would be showing for doing diabetic vitrectomy. I think the most important thing is to identify the right plane of dissections. Once you are in the right plane, the rest of the surgery becomes quite simple. Important to choose the cutter which allows you to work very close to retina. I mean, we do have up to 10,000, which may not be always required, but a good cutter is very important for diabetic vitrectomy. So to show you example of how anti-VEGF work and how you can actually resort to a single instrument vitrectomy without doing anything. Now, this is a patient with diabetic TRD. As usual, first you do core vitrectomy, making sure the entire vitreous which is in the core is clear, and then you identify the plane. The plane where your membranes or fibrovascular proliferation is away from the retina, and this is the plane from where you are able to enter, insinuate your cutter, and here you can see there is a node attachment. You are not seeing anything, but the proportional reflux is being used because that causes the egress of the fluid and makes the fibrovascular membrane separate from the retina or gets elevated from the retina, and then it becomes very easy to start cutting it, and you don't need, honestly, any other instrument to do it. So again, to show that how you would go slowly one by one, trying to separate the adhesions from the underlying retina, insinuating, cutting it, dividing it into different segments, and finally moving to the periphery. Mostly in diabetics, this is again the proportional reflux, which is separating the peripheral vitreous from the retina, and you can go up. Unlike vasculitic TRDs, which I would be showing subsequently, the diabetic TRDs fortunately do not have much in the periphery. So this is the patient, the same patient before and after surgery. The third important point is that there can be intraoperative bleeding. So once there is blood in the intraoperative stage, it's very important to take care of then and there only. Because the problem again in diabetics is when there is a blood, they kind of tend to form fibrin. So if you are handling something else somewhere and you think you will come to this area later, by the time there will be huge clot with fibrin which will be glued onto the surface of retina, and you will have to spend time to separate it. Now you can see here, there is a bleeder, there was a bleeder here. So the endodiathermy should be done there and then. These cutters allow you to go very close to the retina, and you may not even have to use instruments or extrusions many a times to separate. And this is what the adhesion is. Like there is a fibrin gets mixed with it, and you may have to spend time to take care of that fibrin and remove it as a clot. So this is the second part, but even if the bleeding is not getting controlled, please go on to raising the pressure and doing. Third very important step is sometimes you feel you have done a very good vitrectomy and you have peeled everything, even as an experienced surgeon. Now this is a patient with combined retinal detachment, had a break somewhere here. Can you switch off these lights, please? Had a break somewhere here, and you can see This fibrous tissue is being removed, and you will see there is a break underlying here. So you think you are removing everything, and as you will see subsequently, I think I can move forward a bit. This is just the technique of segmentation. Then there is another area of proliferation, which again is taken care of separately by cutting it from the nodes. So once you have completed it, you feel probably you have removed everything and there is no hyaloid because you have tried to look for the hyaloid, you have tried to separate it. But never forget to inject triamcinolone, because as you see, that even after the complete dissection, there is still the whole lot of the schisis part of the hyaloid, which is attached and which needs to be taken out. So vitreous schisis in diabetic retinopathy plays a major role. The fourth component is microscope integrated OCT may help to identify the nodes, may help to identify even the schisis cavities which you have. And this is just to show the video of a diabetic detachment. First is you have done the core vitrectomy, and this is the node where it is firmly adherent. You can use microscope to decide your plane, like where it is, cutter is going and how far is it away from the retina. OCT intraoperatively can guide you. Not only that, OCT can also help you to identify the vitreous schisis. And this is what I'm going to share because I think my time is running up. So if you do not want to, for whatever reasons, you can see here the splitting of the vitreous into the two, and you know that your cutter has to cut not only the superficial layer of the vitreous, but also the deeper layer of the vitreous because of the schisis. If you are not using OCT, safest bet is to use triamcinolone acetonide. Bimanual dissection, these days with the kind of the cutters and all we have, honestly bimanual resection is not needed many a times, but still there would be cases like this where you have to resort to bimanual resection, so don't hesitate. I generally use cutter a lot and proportional reflux a lot, so even for bimanual resection you can see here the cutter is being used to create the plane. And this is the proportional reflux, which is going to help separate the fibrous membrane from the underlying retina, and then you can start segmenting it into multiple quadrants and chopping off those quadrants. So patience is kind of required. Changing the direction of the cutter sometimes is important. For example, here you would see that I was trying to insinuate from here, but it's not comfortable to the surgeon, and my time is up, 1 more minute. So if it's not working in this direction, move to the other direction where you may be able to find a better plane like this, and you are able to go, you are able to cut it, you are able to segment it, and finally it works better for you than the previous one. So if you're not comfortable going in from one direction, just change the direction and move on. The last 1 minute I'm going to take to vasculitic TRDs. Now, unlike diabetics, they have very firm adhesion to the vitreous and in the periphery. So the posterior pole is easy, but the moment you reach the mid-periphery or the periphery, you will see, now here you can see, unlike diabetics, dissecting the posterior pole is quite easy. You can separate these membranes, but the problem arises when you reach this area. This is where they have very firm adhesions, and you will end up creating the iatrogenic breaks. But the fear of the break should not stop you from doing a good dissection. You still have to, here you can see, you may use forceps, but again, they are very firmly adherent, so you may end up with breaks, which at times you may have to support, but a good laser and good dissection, there is no, alternative to it. So I'll skip the last video, and I think only one word in conclusion is to patients. Go slow, manage the things as they come along, and try to do a good and thorough dissection for both the entities. Thank you so much.
Thank you so much, ma'am. I think you covered the topic very extensively. If I may just ask one thing, a lot of times the key to diabetic vitrectomy is that we avoid making a break when there is a TRD. But once we have a break, it starts getting very bullous and things go bad. How would you proceed once you know there is a break and fluid starts seeping under the retina?
By and large, the diabetics would always have the fluid under the retina because even if there is a tractional detachment, there is a subretinal fluid. Only thing when we are not creating a break is we are hoping the retina will settle down on its own once we have done. But when we create a break, which happens most of the times or quite a few times, then it's better to take your cutter on a suction mode close to the break or a flute needle and try to aspirate the fluid. Once you, because it's a thick fluid, so you will need active thing. It doesn't come up like bullous retinal detachment of RD. So once that fluid is come out, you will see the retina settling down, and that actually makes rest of the dissection easier because now the retina is gone back.
A lot of times, ma'am, the break happens right around the arcade where the nodes are there. There is a lot of bleeding over there, a clot forms over there. Would you be aggressive in that first setting, or is there a chance that we may come back if required and leave the clot over there and try?
There was a time when we used to think of coming back, but these days with the preoperative anti-VEGF and with the kind of the instrumentation we have, I don't think we have come back in a very long time. Because I remember long time ago, the bleeding would not get controlled. They will keep on bleeding, then you have to close and come back. But these days, that really does not happen. And the thing is, as soon as you see a bleeder, you have to, like I don't know, but I work very quickly, just go to 60, get my diathermy, bring it back to 30 when it is diathermized to see whether it is still oozing when you bring the pressure down and sort it out. Because that time the temptation is, since you are cutting, you finish the cutting and then come back to the bleeder. That sometimes creates a messy situation.
Yes.
Yeah, totally agree with you. That's why. But only thing is, to answer again one more addition. If you have a bleeder, unfortunately certain situation you just cannot control. Probably we still once in a while do, though routinely we do not. But if you have created break, probably it's not a good idea to come back again. Because once you have break, once you have a blood there, it can be good cocktail for PVR. Then difficult to handle later on. Only bleeding. You are ensuring that there is no other break. Probably these are the situation once in a while, though Dr. Vishali rightly mentioned, most of the time with anti-VEGF we do not have to deal with that, so you anticipate pre-operatively and add on anti-VEGF. But still once in a while it happened, things got delayed because of fitness, we could not have a surgery, and then you have rebound phenomena. And that situation, if you intraoperatively you feel is bleeding too much, not getting control, we want to stop before you create a break.
Right.
Thank
and
you.
so one last question to you. I have seen you work on pressures of 100 for diabetic vitrectomies and prefer not to do a diathermy. How much pressure would you say we can go to, and how much time can we stay there before we say, no, this needs a diathermy?
No, not really. 100 pressure, very, very rarely, because that was a patient probably you were that day. Yeah. It's a systolic pressure going on 210, and even if raising 60, 70, 80, 90, 100, just bleeding was not stopping. There are two reasons, high pressure and patient has a nephropathy also, so it was not clotting as well. Generally, we won't go around 50 or 60, maybe few seconds you wait, and incremental decrease, what Dr. Vishali rightly mentioned. You don't want to bring down immediately also. So go to every 5 millimeter of mercury every few seconds, wait, look at it. If not bleeding further, go down. Not bleeding further, go down. But the moment suppose you start oozing, you can probably again raise maybe 10 millimeter of Hg. Wait for a while, again go that way.
Right. Thank you. Thank you so much, ma'am. Now I'd like to invite Dr. Mohit, who will be talking about the complex rhegmatogenous detachments, mainly the closed funnel ones, the opaque corneas, and hemorrhagic choroidals. Dr. Mohit, please.
Thank you, SIMAR, and thank you for the opportunity. I'm going to get straight into it and basically show 3 different cases because this is a video-based instruction course, and discuss them as we go along and try and point out certain key steps in managing these patients. So the first one is a very short, crisp history, and then we come to the video. So it was a 14-year-old boy who was referred as a 14-year-old boy who was referred as a case of a total retinal detachment with advanced PVR, having had undergone PPV for a traumatic macular hole, which was done elsewhere. So when he came, I'll soon be showing you what the picture was. So I began by, tagging all the muscles. He had a PVR D2 configuration, a narrow funnel, and I actually tied a broader encircling element. That was a 242, and that's the appearance of the retina. And mind you, in cases in which there is a re-retinal detachment post PPV, the PVR tends to be very aggressive and very fast. So because there was a lot of anterior PVR also, although the lens was clear, I was pretty sure that there was extensive base dissection that would have been required. So the lens was sacrificed fairly early on, despite the good view, but that was basically to get access to the vitreous base. One good thing, if I can say, in these badly PVR stricken eyes is that generally the membranes tend to be mature, at least some of them. And the membrane which is actually causing that funnel to form and go down, as in this case, as you can see. So I think under higher magnification, with the disc being as your guide, one should, and you should try and grasp the membrane from there. And in a lot of cases, you can actually get it out fairly to the equator, maybe a little anterior to the equator, as you can see, in this patient. And this comes across. Comes off akin to hyaloid, and beyond a point you will, realize that it is not going anymore, and that's the time to stop. Once the posterior membranes are off, I think PFCL is your, best friend in this case. You put in PFCL, open the funnel, and also stabilize the posterior retina, and just to be doubly sure and ensure that you have removed all the membranes. I think staining in these eyes is very important, because we don't want to remove the ILM for any other purpose but to ensure that the last cortical layer of vitreous is off of the posterior pole. And after that you can then get to work with at the equatorial and the anterior to equatorial adherent hyaloid. So that was the break, as you can see, which was the causative break. And once I was able to get it all the way off, when I thought the hyaloid, all the way up to the posterior edge of the broad encircling element, I think that's a good time to try and stop. Following which, more of PFCL is injected. You go out, you do your inferior endos PI, and then in this patient, I actually went ahead and did a 360-degree Barrard laser, followed by a direct PFCL silicone oil exchange. At least in my hands, I think that tends to work pretty well. And that was the picture at the end of the surgery. So just a few pointers on advanced PVR cases, especially post-PPV. The second case that I'm going to show is so this unfortunate gentleman actually had accidental blast injury and had bilateral open globes repaired elsewhere. One eye was thicycle, the other eye had that appearance and multiple foreign bodies on ultrasound. So we planned to do a combined temporary keratoprosthesis assisted procedure. That was the cornea. The corneal surgeons were with us on that one, and after trephination with a suction refine, the corneal button was removed, as we can see, and that is the cataractus lens. And an open sky ICCE was done, and you'll soon see that we were able to get this large corticonuclear complex out, and then there was a little bit of hydration to remove the remnant cortical matter, and then the Eckart's temporary keratoprosthesis was soon in place, followed by 25 gauge vitrectomy setup. All of those things that you see are actually sheets and sheets of intragel altered hemorrhage, and which is mimicking retina. However, you can see that there are no blood vessels in it. So then you tend to, make an opening in the upper nasal area, and once you know where the retina is, then you work around it. So this patient actually wasn't that bad. I mean, the retina. He did have a retinal detachment, had a posterior break, also had an inferior retinal detachment, and there were multiple of these, chalk-like yellow-colored glistening foreign bodies in the vitreous and in the subretinal space. That was the causative break, as you can see in the infranasally. And after kind of making sure that the edges were regular, we can see that there are those chalky white, dull-colored foreign bodies even in the subretinal space. So, time was taken, and it took a long time to remove each of these foreign bodies, since not all of them were unable to be chewed up by the cutter. So they were actually removed through the anterior route, following which, just to ensure that all the hyaloid was off, I tried to peel as much of the ILM at the posterior pole as possible. Went in with PFCL, and even after that, the nasal retina, at least in a couple of clock hours, seemed to be very gliotic and very shortened, and I felt that needed to be cut, and that's the time that that was done. And following adequate relaxation of the retina, there was a complete PFCL fill was done up to as close to the brim as possible. And bubbling tends to happen because the K-probe will sometimes leak, but that needs to be taken care of, followed by a near confluent laser to the edge. And again, because this was a one-eyed patient, so I did some extra laser also, and this was followed by direct PFCL silicone oil exchange, as was the case, as was done in the last case. Following which, the cornea surgeons were brought back again, the temporary keratoprosthesis was removed, and optical quality graft was actually sewn in place with interrupted sutures, as you'll soon see. And as silicone oil tends to leak in this, during this suturing. So one port was left in situ, and as and when there was hypotony, we did top it up. This patient did fairly well. Had a fairly clear graft, and at 1 month follow-up had 2/60 vision. We have now 9 months of follow-up on him. The pressure is on the lower side, and silicone oil removal is going to be a big challenge for him. But given that he had a bilateral, very severe chemical injury with opaque corneas, I think the outcome was fairly good. Simar, do I skip the last one in the interest of time, or? Fair enough.
Thank you, Dr. Mohit. So I have just one question. I think I'll ask Dr. Pramod that if you have any experience with endoscopic vitrectomy in such cases, sir, and what's your take on that? Would you prefer that or using the temporary K-Pro and going the way Dr. Mohit did?
Actually, endoscopic experience I have very limited. We do have, but somehow I am still not very comfortable. Few cases we tried, because view is limited, whatever said, and particularly limited dissection, taking biopsy or taking out only foreign body, dealing with the extreme anterior area, to some extent you can manage. And particularly I would say 19 gauge is better than 23, though we have 23, 25. I realize, because with the experience, and when I had a difficulty, you go back and read and look at it, realize the 19 gauge, you have a much more better brightness, and field also you get relatively better. But nothing like what you are doing it. And when you think there is extension to the case, what you are saying, I don't think you can manage that entire case with the endoscopy. Yes, theoretically nice. You can probably save the cornea, particularly when you are always shortage, you manage, finish surgery, and then second sitting. If you do while SOR, you are removing the cornea, doing a grafting, acceptance rate will be very, very high. This case, invariably, long term, when you look at it, they undergo re-PK. But primary goal, when we have a reattaching the retina, and you want to do a clean, neat job, probably there is no substitute for this. That's what my personal thing. Of course, with time, we may change, because we'll have a better and better endoscopes, which may give us a wide field, but it is still two-dimensional. You need a lot of experience. And most important thing, what I realized, there is no marking on endoscope which is which meridian. And by chance, once you are rotated, your whole orientation is different. What you are seeing in a screen, which like a clock hours, everything goes up. So every time you come out, you look at the screen, check, this is my 12 o'clock. It's like an ultrasound or other instrument, you have that marking. You know, this is my 12 o'clock or this is my 3 o'clock. There's unfortunately nothing on that probe. So sometimes it's difficult. You can very easily miss that orientation.
Right. Thank you. Thank you so much, Dr. Mohit. Thank you. And now I'd like to invite Dr. Pramod Bhende sir from Shankara Netralaya, Chennai. And he'll be talking about coloboma-related detachments, and I don't think there is any better person for that. Dr. Pramod, please.
Thank you very much, Dr. SIMAR, for having me here, and just it's a pleasure. So basically, just a little bit pathoanatomy. In a choroidal coloboma, retina splits near the margin of the coloboma. So inner retinal neurosensory layer continues as a ICM across the coloboma, intercalary membrane, you talk about this. An outer layer turns back to merge with the RPA, which forms something like a hump-like thing, the sharp margin, and where you have a VR attachment are very strong, but at the same time, it forms a zone of what is called as local binaries resistancy, where holes can very easily form between RP choroid and retinal junction. So that is the commonest location, weakest area, and that's why you cause release resistance or locus minoris resistancy. So these eyes are a little bit different because very high incidence of detachment, and detachment and location of break, they do not follow classic whatever rules are taught to us by Linkoff and Shippen. Principles of retinal detachment management cannot be applied here, and you need to differentiate where you are dealing with a coloboma-related detachment or coloboma-associated detachments. So we'll come to that in few minutes. So when you look at a retinal breaks, you can have the breaks within the intercalary membrane, can have at a locus minoris resistancy, or have a peripheral break without having any break in the coloboma. And RD configuration depends on where the break is and combination of these things. So if you have only ICM break, probably you can have a detachment in ICM, and which is very common thing, but there is no other peripheral retinal detachments. So obviously you do not have to do in these eyes safely, you can wait and watch. Question of prophylactic laser probably we can discuss when later on if necessary during discussion. But if you have only peripheral break, now RD involves the normal retina and generally stops short of coloboma. So there is no continuation within the ICM or within the coloboma, and now these eyes behave exactly like what we have our conventional rheumatology detachment, and you can handle all principles like scleral buckling or vitrectomy depending on location of the break. Ignore the coloboma here, and this is one of the case where we did just scleral buckling and patient is doing very fine. So now you can have a peripheral break and break in a locus minoris resistancy. Now what have you have a detachment, the normal retina, and with variable ICM detachment, which spills over in a coloboma area, but you cannot see the demonstrable break probably in ICM, or generally break can be near the border of coloboma, which clinically impossible to locate. And these are the eyes need vitreous surgery. This is just our article from Dr. Gopal, first author, and you see the OCT we did, and it's showing the break in that ICM area here, which very well picked up on OCT and closure of the break after vitrectomy. Now the last one is ICM break and break at a locus minoris resistancy. You don't see any peripheral break, and this is a commonest combination what you see in coloboma detachment, where you have a ICM detachment which extend onto the normal retina to a variable degree, and there is no peripheral break seen, and these eyes definitely need vitrectomy. So coming to the surgery part, we all have conception that in coloboma you need a sclerotomy to be done anteriorly. These are microcornea, microphthalmus. But if only microcornea dealing with, in fact, looking at the other publication and your common sense situation, in fact, the distance between limbus and ora is much, much more, so that you can even do conventional 3.5 to 4 millimeter sclerotomy away from the limbus. So yes, we need to take some specific precaution. Whether to sacrifice lens or not, we need to decide about that, because generally lens is very hard and much, much larger compared to corneal size in these eyes, and very high risk of touching the lens. So when you make a sclerotomy, you ensure, and because with all of us, I think sitting here are having a good experience with ROP, lens sparing vitrectomy, if a sclerotomy while making your blade goes a little bit parallel to visual axis, most of the eyes we can see the save the lens in these cases. So, sorry. So as I said, lens can be almost a normal size, and we most of the time now prefer to leave lens behind, so I can be faking, because we all these eyes are young guys. So accommodation is very, very important. But once you decide to remove the lens, probably it depends on location of pathology and how anterior dissection needs to be. Yes, you keep in mind age can be very deceptive, lens can be extremely hard, and even sometimes 14-year, 15-year-old guy, you may need to do fragmentation. You may not be able to remove the lens with your conventional cutter. So what I do is sometimes these eyes try to retain the anterior capsule, because invariably you are going to put a silicone oil, but quite some time you may not be able to save that, and particularly there's a risk of having a capsular fibrosis later on, and sometimes persistent hypotony. So case to case you take a call accordingly. So coming to vitrectomy, need to debulk the vitreous, and most of the time again these eyes do not have PVD, and induction of PVD is extremely difficult. You have to be persistent, you have to keep on trying multiple attempts. There is a high risk of creating iatrogenic break, as you see here, and then while induction here you see now, and suddenly retina get caught into the port. So, and while pulling the vitreous, while separation, it adds on the tuck near the locus minoris resistancy, and that itself, your act itself can create a break at a locus minoris resistancy. Generally, there is no PVR in a primary cases. So, this I already covered. So, this is another iatrogenic break this case had. So, when you're doing a fluid air exchange, there is no need to suck the fluid from ICM break. You just be in a coloboma area, start fluid exchange. Generally, SRF drains to the breaks in a ICM coming into coloboma area, and most of the time retina flutters there. So, if there are peripheral breaks, you can even try to drain to the peripheral break, but if not, then you need not make any peripheral sclerotomy, sclerotic retinotomy to drain. Fortunately, this eye had a peripheral break, which is iatrogenic in fact, so I could drain to that break and flatten the retina. So, and once retina is flattened, again, how to deal with a detached ICM? Usually we can leave it behind. Even if it's taught, generally it does not cause much problem. Okay, but if you are really worried about, you can either give relaxing cut. There are a few reports dissecting out the ICM, but issue here is sometimes large blood vessel can be crossing across the ICM and coming back again on the normal retina. And if you cut those, obviously you are compromising the retinal circulation. So take care of those blood vessels before thinking about taking out ICM. So laser generally to the peripheral breaks to cover entire border of the coloboma, as you see here, and all around 360 degree, because ICM breaks sometimes difficult to recognize, and so it's better to seal that entire edge. And you have, if they are very close to the optic disc, probably red laser is better off than using conventional green laser. Internal tapered, of course, silicone oil is preferred, and these are few results I am just skipping through. But what we wanted to tell you is like almost 85% patient our series did not have a PVD, and most of the overall success rate was almost 95 after a silicone oil removal. But what was important is 32% of patients had increased intraocular pressure. So when you deal with this patient at the end and follow up, when you look at it, coming to conclusion, post-surgery, though your functional outcome, anatomical success is good, these eyes need to be monitored for intraocular pressure during their post-operative period. Thank you very much. I'll stop here. Thank you once again.
Thank you. Thank you so much, sir. I think you covered the topic very extensively. And just as Dr. Diksha gets ready, if I could ask you just the role of laser in the other eye once you have a detachment in one eye with a bilateral coloboma. Would you do in all, or are there certain indications for you? Well,
it's again a controversial topic. If you have a RD in one eye and other eye coloboma is not involving disc and macula, yes, I would go ahead with laser.
Right.
But if disc and macula is within the coloboma or partly covering, and our fovea is right on the edge of the coloboma, probably I'll have a close follow-up rather than doing, because sometimes your laser itself may knock out macula or cause photic damage to the optic nerve, and that's why we will be hesitant. Now, sometimes people take again hybrid approach, do entire edge and leave that area macula and disc as it is. But that is taking chance, because you assume that break may be somewhere else and maybe hold it on. And exactly so it is there, then you miss it. But you take the chance. You feel maybe more secure that way. So that can, but if disc and macula is within the coloboma, I would prefer not to.
Right. Thank you. Thank you so much, sir.
Thank you.
And now I'd request Dr. Diksha, who will be speaking on retinopathy of prematurity and ophthalmos-related retinal detachments, and ma'am has done some really challenging cases in both these indications. Dr. Diksha, please.
Thank you, SIMAR, and thank you for the opportunity. So, most of the time when we treat timely, retinopathy of prematurity generally tends to have an excellent outcome. However, there may be cases where there is delayed presentation, most of the time due to lack of timely screening in our country. And this is where these children present with cases with stage 4A, 4B, and 5, where we need to operate them. Also, worsening fibrovascular organization despite treatment would be an indication now, considering an earlier approach. Apart from that, media opacities are another indication. The surgical approaches include scleral buckling, lens-sparing vitrectomy, and lensectomy vitrectomy. Scleral buckling, popularized by Dr. Michael Tracy, has a decent, significant anatomical success rates of around 70% for stage 4. However, the anisometropia that is induced often leads to poor visual acuity and often requires a second procedure, that is the buccal division. Lens-sparing vitrectomy at this time is the most commonly performed surgery for ROP, whereas it started with the 2-port with an infusing light pipe by Dr. Michael Tracy. Most of us are currently doing the 3-port vitrectomy with either a 23, 25, or 27. I personally do most of my cases with the 27 gauge and some of them with the 25 gauge. We know the anatomical considerations of the premature infant eyes, wherein we know that the lens is globular, requires a larger space, and also the axial lens are smaller, so we need to go in almost parallel to the visual axis. As far as these sclerotomies are concerned, less than 6 months we have to remain within 1.5 millimeters. So generally 1 to 1.5. 6 to 12 months around 2 millimeters, and 1 to 2 years 2.5, and then 3. After 6 years we can go to 3.5 millimeters. The timing of surgery ideally should be when the vascular activity is regressed. However, some of that may not be possible, and then we need to sometimes use anti-VEGF as a preoperative adjunct before surgery, or even add on to supplemental razor. The preoperative considerations are the most important. Sometimes we have to decide for a bilateral sequential simultaneously surgery when both eyes are progressing. Major anesthesia concerns include hypoglycemia, hypothermia, apnea, anemia, and need for postoperative monitoring when we need to have an experienced surgical team. The basic principles will be, I'll be just showing in this surgical video. Audio. The audio.
Can we have the audio, please?
So basically this is a case of a bilateral aggressive ROP in zone 1, and we can see that there is already preoperative, pre-existing fibrovascular proliferation. Is it?
So both eyes supplemental laser was done, and both eye lens-sparing vitrectomy.
So
with preoperative
there's no audio.
Laser and injection anti-VEGF, we can see that there is reduction of plus disease. However, there is persistence of fibrovascular proliferation along the arcades. We can see the basic setup for a 27 gauge lens-sparing vitrectomy. The first important step is making of sclerotomies. Sclerotomy is made for infusion cannula 1.5 mm away from the limbus. Conjunctiva is slided and entry is made perpendicular to the visual axis while avoiding inadvertent injury to the crystalline lens. Similarly, 2 more sclerotomies are made for endolite and cutter. This is the intraoperative view. The core vitrectomy is now started. The principle of LSV includes release of various vitreoretinal tractional forces as shown in this diagram, which here is synonymous with the fibrous proliferation along the arcades. Here we can see that the adhesions between the ridge and the lens are being removed, followed by release of adhesions between the ridge and the periphery. Intraoperative OCT can be a useful adjunct in ROP surgery. It can help in identifying the membranes and can guide their removal. Triamcinolone acetonide is added to stain the posterior hyaloid. Even though the complete removal of posterior hyaloid may not be possible in these eyes, here an attempt is made to remove the hyaloid between the arcades, followed by fluid air exchange. Any residual peripheral vitreous can now be removed under air. Fluid air exchange also helps in tamponading the ports in case a sutureless vitrectomy is planned, as shown in this case. Now the cannulas are removed and the ports are left sutureless. This is the outcome at 2 months. We can see that there is reduction of plastices and arcades are now free of traction.
Sometimes we need to reduce the, we need to go in with shorter instruments, commercially available with Alcon, and there's a special pediatric set. However, we may have to do it ourselves, wherein what has been reported is use a silicone small segment to shorten the length by around 1 millimeter. We need to do different approaches. For example, this is a case of a stage 4B wherein there is no space between the peripheral TRD and the lens, and then we need to go all nasal. This is a technique which has been published by Professor Dogra, and sir is in the audience. Herein we need to, what we do is all the 3 ports including the infusion cannula, the cutter and the endolite are placed nasally with the infusion cannula in the center, and then we proceed with the vitrectomy. The vitrectomy principles remain basically the same, I use triamcinolone more often nowadays because I've seen that there is always some amount of a partial separation of the hyaloid, and the triamcinolone helps us to identify that better. A complete PVD is not possible in most cases, but even a partial, especially at the posterior port, does help in improve the anatomical outcome, especially of the posterior pole. So it's the same case post-surgery. This is a small video of stage 5. I think we'll need to skip it because of the lack of time. The complications associated with lens peric, most commonly I've seen a vitreous hemorrhage. Most of the time it's going to resolve over next 4 to 6 weeks. After that we have cataract, as rarely and most dreaded is rhegmatogenous retinal detachment, endophthalmitis, glaucoma, and persistent retinal folds and retinal detachment. Coming on to ophthalmos, the overall incidence is around 4%, increases with the increase in the axial length. The challenges are the hypotony, choroidal detachment, Harb stria, scleral thickening, trabeculotomy brebs, glaucoma drainage devices, and the post-operative IOP control. The basic principles remain same, like for vitrectomies, especially the ones, I think Dr. Mohit, these are the type of cases that we see with ophthalmos. I don't know we have time for this video. This is just one case I want to show, one-eyed child, 5-year-old, who presented with a rhegmatogenous macula of retinal detachment. In the only seeing eye, she had undergone 5 previous surgeries, and this is a detachment. So just the steps. In this case, we did not do a pars plana vitrectomy. We wanted to do a scleral buccal, but how do we do it in the presence of a pre-existing glaucoma drainage device? So I think it was Dr. Sushmita who suggested that please don't remove this device, do something so that you can use that as a scleral buccal. So the most important step here was the ligation of the tube before the incision of the fibrous capsule, otherwise there is a risk of hypotony. After that we just trimmed this Adi implant after excising the capsule and used this as a component of the scleral buccal along with the 277 tire and the 240 band. This is the post-operative outcome for this case. Thank you.
Thank you so much, ma'am. I think they were really challenging surgeries, and if I could have a quick comment from Dr. Dogra, who's actually taught us everything and anything about ROP and ROP surgery. If I could have a quick comment from sir, please.
Thank you very much, Diksha. It makes me feel proud. I can only say that. The type of surgery you are performing, all challenging cases, I think I have no comment, but my best wishes. Keep on doing great work. That's it.
Thank you. Thank you so much, sir, and thank you so much, ma'am, for the presentation. So I'll move on to the last presentation, that is mine on surgical management of advanced Coats disease and familial exudative vitreoretinopathy. We'll see how much we can cover in the time that we have. So Coats disease is an idiopathic retinal telangiectasia and has been classified broadly into five stages. And the role of surgical management mainly comes in with stage 3B and stage 4 when you have a total exudative retinal detachment with or without neovascularization. So the role of surgery is debatable, but yes, we know from the natural history of the disease that if we are going to leave these eyes as it is, a majority of them are going to go into neovascular glaucoma, and a lot of them will require enucleation for a painful blind eye. So the aim of the surgery is actually to prevent that complication. The visual gain may not be as much, but you are actually trying to save the eye in its anatomy. So just one example, one surgery I'll show. This is a 7-year-old male child presented with right eye xanthochoria and exotropia for the last 6 months, was brought by the parents. And you can see that total exudative retinal detachment with those subretinal exudates. The telangiectasia are not actually visible here, but one thing that is most important in these cases is to rule out retinoblastoma. The age group matches. Most of the children who present with stage 3B and stage 4 are younger children. They are around 5-6 years of age or even younger. And those beyond 10 usually do not come to us with this kind of presentation as far as I have observed. So an ultrasound and a CE MRI brain and orbit are absolutely essential so that you can rule out retinoblastoma as surely as you can, and only then proceed with intervening in such eyes. Parental counseling is also important to get their expectations to what can be expected out of the case. Again, as I said, is to avoid a painful blind eye, and the visual benefit may be minimal, and repeated procedures may be required. And also that the exotropia will not be treated with this. So this is just a case. As you see, the retina is lying right behind the lens and those mobile subretinal exudates over there. So I put in a traction suture at the temporal limbus, and about 8 to 10 millimeters from the limbus, localized peritemy is done. Just a localized incision into the conjunctiva and the tenons to bear out the sclera over there, a small amount of diathermy so that there is no further bleeding. And then I prefer to do a direct cut down. Somehow with the cannula drainage, I am not very comfortable with going in the subretinal space. And an AC maintainer is put in at this time so that the globe is pressurized and the egress of the subretinal fluid is aided with the same. A direct cut down is done in the sclera. You have to manage the quadrants in such a way that when you are pulling the eye towards one side, your AC maintainer and the cut down are almost in the same quadrant. And then drainage with the help of a 26 gauge needle. You can see the refractile crystals coming out here, and it takes a lot of time to drain this fluid, and unlike scleral buckling, most often you have to keep your needle over there because that opening tends to close. The fluid is very thick. And then I just put in a chandelier. You can see most of the fluid has been drained. The retina is largely settled, but you can see these vitreous strands over here. So this is something that I have done recently, just going in with a vitreous cutter and kind of dissecting these strands, because post-operatively I saw that there was a lot of fibrosis happening in these eyes. And then you can see this telangiectasia interiorly in the inferotemporal quadrant, and a direct long duration laser can be done to these telangiectasia to treat the primary cause of the detachment. This is actually the most important step, and I prefer to leave just a small bit of triamcinolone at the end of the surgery that helps aiding the inflammation that is there and resolving the rest of the subretinal fluid. So this was the picture of the child 20 days post-operative. Now we have had experience with some of these cases where they do well, and of course sometimes require repeated interventions. Again, another exudative case that did well following the surgery. Another advantage is you can take a sample for diagnostic cytopathology just to be sure you haven't entered a tumor eye, and you can get the analysis for the same as well from the subretinal fluid. So important considerations, I think I covered most of these. I'll quickly go on to FEVR. We have a few minutes. So again, in FEVR, the main indication for detachment comes in with stage 4 and stage 5 FEVR when it involves the macula. And Dr. Tracy was the one who showed us that yes, surgery can help in FEVR cases, though the outcomes may not be as good as others. So we would all like to have cases like this where there is no detachment yet, just neovascularization, and we can just laser them up. That is the most ideal scenario. But we often get these cases like this, as one-eyed child which presented with a combined retinal detachment and a lot of neovascularization and hemorrhage. So I'll quickly go through the surgery and we'll know what challenges we usually face in the same. So put in a 277 tire in the temporal half to support that, to give some extra support. And then started with the vitrectomy. You can see the retina is pulled up very anteriorly. The ports were going through the retina even at about 3.5 millimeters. So that is one thing that you need to take care of and examine preoperatively with a EUA. And then the hyaloid removal is actually very tough in these eyes. So use of triamcinolone and regular bimanual procedures also help. And you can see that you can just get it up to where the neovascularization is present. Beyond that, it is still very difficult. So the role of the encircling elements comes in very handy here. And they often have this kind of membrane right over the posterior pole that ultimately causes the falciform fold-like picture also. And removing that is important. And as we saw earlier, once you have dissected the proliferation or the hyaloid from the posterior pole, PFCL really helps as a third hand for further dissection. So even after doing all this, I decided to give a trial of fluid air exchange over here. But as you can see, this whole retina, the air went subretinal and the retina was kind of tenting up. So there's still a lot of stiffness in the periphery which was not getting supported. I tried doing the retinectomy under air to see how much relaxation would be required, but the retina was kind of flipping over. So went on fluid and completed the retinectomy for about 120 to 150 degrees. And then again put in PFCL, which settled the retina, laser and cryo to the anterior flanges, and finally PFCL air and air oil exchange. So this was post-operative. So I'm just going to finish here that yes, actually the incidence of FEVR is much more than we have seen. Early intervention with laser may prevent progression, and despite laser of almost 50% of these cases, the vitreopathy progresses and kind of forms traction and the detachment. Peeling of hyaloid from the retina can be extremely difficult, and interiorly pulled up retina should be considered while entering the eye. And finally, do not forget the family. It is an autosomal dominant condition. Please examine the family members. They will have the same. And as goes with all pediatric surgeries, coats and FEVR, the lesser you can do and give the outcome, the better it is. Thank you so much.
Yes, one comment.
Yes, sir.
Yes, I agree with you. Rightly mentioned, when you are dealing with the coats, you need to rule out retinoblastoma. But we need to also understand Coats disease can have a ocular coat calcification as well. So you need to differentiate. Just because seeing a high reflective echoes does not mean that retinoblastoma is there, so that thing need to be kept in mind.
Right. Thank you. Thank you so much, sir. I think we are out of time and we'll like to proceed with the next session.
Thank you.
Vishali ma'am, please.